Cast is now starting. All attendees are in listen-only mode.
Hello and welcome to the February 2020 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey, and I'm here with David Page, who will be with his workshop group today, and with Dr. Bill Toon, who will be joining us shortly. And the study we'll be reviewing today is entitled Advanced Placement Paramedic Education for Healthcare Professionals, a Descriptive Evaluation. And this was published in January 2020 in the Journal of Emergency Nursing. So we also, before we get going here, because we have a full complement of authors today, we want to remind everyone that there's an upcoming abstract deadline. The PCRF, as you know, partners with the National Association of EMS Educators and EMS World's International Scientific Symposium, and we have the call for abstract, the deadline coming up for all three clinical and systems and education abstracts is May 31st, 2020. So we've got a little bit of time, but not a whole lot. So warm up your databases and form those research questions and start thinking about submitting your abstract on the PCRF website. We'll have a little bit more of that at our next podcast. We'll talk a little bit more about that in March. But you want to submit those abstracts. If accepted abstracts will be presented at the International Scientific Symposium if it's a clinical or systems abstract, and that'll be in October in Las Vegas, I believe. And then the education abstracts will be presented at the National Association of EMS Educators Symposium, which is in Pittsburgh this year, and that is in August. So more on that in the next month. So thank you all for joining us today. We're going to begin, and we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we will bring those into the conversation as we go. So a little bit of background. We know in the United States, the National EMS Education Standards, the EMS Scope of Practice model describes the 4 levels of EMS practitioner: emergency medical responder, emergency medical technician, advanced EMT, and then paramedic. And we know that varieties of models of practice exist around the world. And in Europe, often we see the RN physician integrated into the field, and in the U.S. and aeromedical and other specialty areas, we may see the same. In education, bridging gaps allows a fluid, and a streamlined process for one practitioner to enter into another field. So in this case, it would be a challenge process. And in this study, one program describes their challenge process and the results of those, the success rates of the challenge process. And this is going from non-paramedic, the registered nurse, physician assistant, physician, or even a paramedic graduate from a non-accredited program into their accredited program, and then measuring their success rate. So they've described this in their study. Now, before going into anything, we might as well just talk to the authors directly here. We have a full complement of authors. So we want to welcome Dr. Bill Leggio, Dr. Michael Miller, both from Creighton University, and Dr. Ash Panchal from the National Registry in Ohio. So we'll start by having them introduce themselves, and then we'll dive right into this study. So Bill, you want to start?
Yes, thank you so much for providing us with this opportunity to discuss and share our collaborative research project here. So I'm William Leggio. During the time of the project, I was assistant professor and EMS or paramedic program coordinator at Creighton University. I am now a clinical operations and practice standards coordinator for the Office of the Medical Director in the City of Austin. So they are affording my time to be here today, but this certainly was a project I did while at Creighton, and I want to recognize both for their support.
Great, thanks. And are you a William or a Bill or a Dr. Leggio?
Depends on the context.
Okay, I'll just call you Dr. Leggio for sure. And Dr. Miller, how about an introduction?
Hi, Megan. Thanks again to echo Bill's sentiments here. Pleasure to be with you and the rest of the group here at PCRF. I am the EMS Education Program Director, Assistant Professor at Creighton University EMS Education. I have been here for 17 years in various capacities and have 35 years of experience in emergency medical services, emergency medicine, and general critical care, both as a paramedic and a registered nurse.
Great, thank you. And Dr. Panchal.
Yes, thank you again for having me. My name is Ash Panchal, and I am an emergency physician. I'm an associate professor of emergency medicine at The Ohio State University. There I am a board certified EM doc as well as EMS physician. And I have the pleasure of being the research and fellowship director at the National Registry. And I'll be helping out with my role on this study through that part.
Great, thank you all for introducing. And Dr. Panchal, you've joined us, I think, before on this podcast or on the clinical one, I think, with some of your research out of the National Registry. So let's start with just what drove you toward this question. So one of the things I want to actually start with is those of you out there listening, there's going to be a lot of opinions and probably drive to talk about the implications of a study like this and maybe the questions that you have. What we'd like to do is let's dissect the research question and the gaps that you identified that you're trying to address and that kind of thing first, and then your methodological, considerations. Let's dissect that first, and then we'll talk about your, just like you do in a research study, and then we'll talk about your, what your implications of the study are. So why don't we start with what drove you to asking this question and conducting this research?
I'll go ahead and chime in with that, Megan. This is Mike. I remember the day very clearly because I was driving through a terrible rainstorm heading to a conference in Nebraska, and we were interested in trying to find some projects to work with Ash and the National Registry on, and this was one of the ideas that had come up. The program is not new that we've been involved with. It predates my arrival at the university, but it is something that a lot of people have, including ourselves, have looked at and gone, gosh, are we actually accomplishing what we think we're accomplishing? Are these students that are participating in this advanced placement process, are they able to successfully navigate the National Registry examination is one outcome metric to try to determine whether or not what we do from a curricular perspective and a selection process and all those other things is actually yielding success. So with that question in mind, we decided to work with Ash Panchal at National Registry and others in an effort to try to go back and retrospectively look at 10 years of data from participants that we've had in this particular course, in this particular format.
That's great. And so you were looking at something that was already in existence. You've already had a challenge process at Creighton. Is that?
Yeah.
And since 2007, or how long have you had this process?
It predates me. I would guess that there's been an advanced placement for at least 25 years, coursework that's been done that was actually designed with colleagues that predate my arrival here. The EMS medical director that was involved, interestingly enough, Dr. Richard Walker, is still affiliated with the program as the program's medical director, and he was instrumental in developing this concept, along with Twink Dalton would be another person that was involved in that process, and people probably know that name. And a crosswalk was basically done at that particular point in time, recognizing that some of these folks wanted to actually become educated and be better clinicians in the out-of-hospital environment, and that they didn't just want to take the credentials that they already had necessarily and try to function in that environment without actually having some education behind them as it pertains to that. And that's how the program has grown and continued to exist all those years.
Now, was your program designed to, fill a local community need, or was it more for, personal advancement and achievement, or, is there something that came from industry advisors, or?
I can't speak to the time that predates me as far as the most recent time period, the last 15 to 20 years or so. I can say there's been a lot of employers that will actually seek to hire registered nurses or others that have a desire to work in critical care types of environments. Leading among them would be aeromedical transport, that they want them to have out-of-hospital experiences and credentials as well. We have seen, even from a military perspective, with our own people that are working in military service, that they have identified that clinicians that are registered nurses and paramedics that are working in critical care transport in various venues, that they actually have better outcomes in their patients as a result of that. There are several states that have come on board and actually require within a certain period of time somebody who's going to be working in an aeromedical transport perspective as registered nurses, that they also be paramedics. So I just think that there's a lot of need out there. Part of it is just an individual from a developmental perspective, recognizing I should probably learn more about this if I'm going to try to function effectively in this environment.
Okay, and you also cite in your background that the COA EMSP survey of accredited programs that showed that in 2015, 31% of the programs offered advanced placement education for healthcare professionals, but only 18% admitted in the last 5 years. So that was something, I think, that identifying kind of the state of advanced placement and where it's headed. And then you talked about what you wanted to look at. The gap basically was we didn't really know too much about the performance and demographics of who are the practitioners that enter advanced placement and what happens to them. And so when you do that, when you address that question, you have two things, right? You have your predictor, which is your advanced placement, who are the students that are entering it, and then you have your outcome, and your outcome you defined. Tell us how you just defined your outcome here that you were looking at. What was success? And then anybody can answer. And let's say Ash, why don't you describe that since you're at the National Registry?
Sure. Actually, I'll have to be honest, Bill was a big lifter when it came to actually looking at some of these pieces, but the outcome variable that we initially thought about was a couple of different pieces, right? So we wanted to first talk about a little bit about how this population is put together. Who are these people? Because the data that COA put out there was a really kind of a general concept, of a general idea of what's going on there. So we didn't really have a great idea of where these students were coming from and things like that. Now, the biggest piece for us was, how can we define if someone is truly entry level? So you've gone through the training, you've gone through the quote unquote challenge process. And so we leveraged the ability for the National Paramedic Certification Exam to be that entry level examination level. And so we actually looked at the outcome variable of their ability to pass that certification exam, but that was the downstream piece, because one of the great pieces that is there at Creighton University, which has been put together well with both Bill and Mike, is the fact that they have a comprehensive program final examination. So that comprehensive final examination was also one of our outcome variables. And we really show that in table 2, where we look at the first attempt and the second attempt on that program evaluation, as well as the first attempt and the cumulative third attempt of the national certification exam.
Okay, so we're using exam as the success. So I'm trying to walk through this. So if you have people out there who are thinking of doing some research, and even if it's descriptive research, they need to clarify when we say, what are success rates? Well, what do we mean by success, or what's the performance? I think you were saying to describe the performance and basic demographics of non-EMS healthcare professionals who attended this particular program. So there's two elements to this, and maybe Dr. Leggio, and I'm going to call you Dr. Leggio because Bill Toon's going to be coming on, and I call Bill Toon, among other things. So I don't want to get confused between the Bills. So Dr. Leggio, can you walk us through then I have the figure 1 up here, and then the figure of the map as well. Describe the population that we're looking at here.
Yeah, so my favorite piece of this is actually kind of the map, because I think the map tells a bigger story of that this is not just a population concentrated to one state or even one region. I mean, you see that, you know, the darker the blue, the more students that or learners that we've hosted from that state. Part of the challenge in that, and what we took a fairly conservative approach in how we collected our data and how we defined some of this. So their state of residency was defined by their driver's license. And so, you know, you got to keep in mind, nurses sometimes engage in travel nursing. And so they may be currently working in a state different than their residency or their driver's license. But so we stuck with the driver's license. And as you see, you know, Nebraska and Colorado are, you know, pretty heavy states, but that's probably proximity. We've enjoyed a number of students from the Pacific Northwest, Texas, and then a few out on the East Coast as well. So the map really shows that this isn't just one state of learners. It really is, you know, there's even students there from Alaska. And so figure one, you know, we did a 10-year span retrospectively looking, and we thought that would give us a good number, and it also was a nice time frame that there wasn't a lot of variability in how a registry was tested, the program exams, and the psychomotor component as well. So we thought that was a nice, healthy time frame to look at. And so the flow diagram just kind of shows, you know, we started out with 305 learner applications and profiles to go through and their outcomes. 34 of those did not complete the curriculum at the time of study. So 271 did complete, 70 of those did not sit for national examination. And so those that we actually looked at their outcomes based on the examination is 201. So keep in mind that when we did this study in 2018, there are some students that were in the 2017 cohorts that may have still been in the process of completing, but because they had not completed at the time of data collection and analysis, they fell out of that. So they're somewhere in those 34 that did not complete. Again, we did that to be conservative. I don't think it had a great, strong impact on what we see for the final outcomes of this study, but I just do want to say that just to be clear on that. So table one is really just kind of our demographic summary. We see that the frequency and the IQRs are there. The one thing we found interesting about this cohort is the breakdown of male to female and how it really does not represent either profession well. You know, EMS tends to be a pretty male-dominant profession, female for nursing. And so here we see, it's kind of almost an even break between the two. And, we thought that was interesting. We couldn't really go too far with that, but it was something I thought was kind of interesting to look at.
Something else interesting is your study period of 2007 to 2017, I believe mirrors the publication in pre-hospital emergency care from the National Registry. I think Dr. Panchal, you might have been on this. Remley Crow, Dr. Crow had presented it as well, and this was really the demographic description of of EMS professionals over a 10-year period. And one of the things that struck me, like very quickly looking at the table of demographics, is the missing elements, and I'm just curious why other things weren't included. So we have male to female. That sort of stood out to me because it's different than what we see when looking at the population of the profession, which is more male dominated. But we're missing race or ethnicity, and then other things that might influence outcome. It may not make a difference because the outcomes are so positive here. However, there's another kind of larger conversation to have later on this. But I'm curious why you didn't break down by other demographics and like ethnicity.
I'm glad to field that. Yeah, I'm actually on that paper as the senior author for the disparities paper.
Yes.
And I think it's the whole question about the disparities that we have both in gender as well as our racial disparities in our EMS professionals environment in comparison to our general public is something which is significant and something that we really need to think about. In that paper, the most telling and most powerful thing that I can give, which is applicable to this study, is the fact that we were looking at the data of people who are just coming into EMS, and over that 10-year span, there was no real change. That means that we can expect that we're not going to have a huge change in our demographic characteristics over time, which is frankly frightening. Now, when we look at this population, we actually were focusing primarily on, of course, the question about how these individuals did going through. We did not focus on the disparities piece, and partly because we had not actually finished the other work where we're like, oh my gosh, this is such a huge problem. And the challenge with this is also how well you keep up the data on all the racial and different demographics piece. And so it was, to be frank, it was not something that we purposely decided to not include versus include. It was one of those things that you're in the process of doing one study, and then you see the other thing, and you're like, oh, we probably should have done that. So yeah, good question.
Well, some of it too, and I think this is important for, again, young researchers out there. It really, what is your research question? And I think maybe because it wasn't put into the limitations, I raise it, because there are other questions that can be added in here that we can talk about in a little bit. But, like, are we, by having this kind of top-down entry into, and I say that with some pause because I don't know how else to describe it, but entry into the profession, what happens to the bottom-up entry into the profession, and that's kind of what I'm getting at, which we can talk about in a little bit. I'd like Dr. Leo to continue through here, though, because I think it's really important that you're able to describe what I think is a really good guide for others who are developing a challenge process, and that is what kinds of requirements you have coming in. But if you can continue to describe the types of providers that you had, what we're seeing here in Table 1, and then describe your the entry requirements, that would be helpful.
Sure. So just real quick with, the further on the personal demographics, I don't know how easily we could have captured that. I'm thinking back to what the applications look like and that kind of stuff. So great point. I will admit there was probably just a little bit of oversight on that. So great point. That should have been in the limitations. So, just kind of going through, the most frequent learner, they were registered nurses, and that's obviously apparent there with the type of provider. It is neat to note that we saw physicians go through this program and see, one CRNA, and so that was always kind of cool. But predominantly, they are registered nurses, and they had attained or completed almost 63% of them at least a bachelor's degree. It is important to note that there were students that were actively involved in completing graduate studies as well, but they had not completed that study at time of application. So we could not capture that. So again, we took a conservative approach on reporting that out. The years of clinical experience really plays into the requirements for this program. So the program requires that they be a healthcare professional that has a deep knowledge of patient assessment, clinical abilities, and pharmacology, pathophys, and so on. And so really the threshold for the program is a registered nurse. We've had requests from respiratory therapists, chiropractors, physical therapists, and so on. And in consultation with the medical director and as a body of faculty, we really didn't feel that those levels of licensure prepared them well for the structure of this program. And so we required 2 years of acute care experience. And acute care experience for the program really fell in emergency department, intensive care unit, some cardiac care, depending on the severity of the patients or the criticality of those patients, and then flight. The program does not require specific experience in EMS other than that they have completed an EMT program and still hold that certification or licensure. But we were able to capture that many of these students, 152 of them, had previous experience working in EMS. And some of that is they were volunteering or working for small agencies, and they were doing this to be a better service or to expand their capabilities in service of their community. We tried to capture some of that along the way, kind of do like a thematic analysis for that, but that information was hard to attain objectively from their application. So that's kind of an anecdotal insight. We know that, as Mike said, there were students in this program because of military orders and service. We had students that we know were in the program for work related with flight. And we also had students that were doing this fairly altruistically because they wanted to better serve their community. They saw that there was a need, as we all know, with rural and smaller areas. So again, the big requirements were those years of experience, because you gotta keep in mind, these students usually have, their licensure provides them with a generalist approach to medicine, where EMS, we develop a specialized approach. But it was their work experience that really helped transfer that closer to EMS, to where we felt, okay, this is a good group. And so there you see, 223 of them were ER staff and 139 were ICU. And a lot of these individuals had multiple buckets in which they kind of had experience, ER, flight, ICU, and so on. So these were pretty high speed, low drag, ER type 1 personalities that we all know and appreciate.
Okay, thanks for describing that. Now, can you take it now to the, and Mike, you went into this a little bit, but walk me through, like, I'm a nurse and I want to apply to your program. I meet the qualifications. I've got my BLS and ACLS and maybe a PALS and trauma certification. I've made it into the program. Walk me through what happens. What do I do, physically? Do I show up for class at certain days? Is there distance education? What does that look like to me?
Yeah, great question, Megan. So since the program, and I've been around the program, since I have been around the program, I should say, there has always been some pre-course work. We would have sent the participants during the earlier part of this 10-year captured audience that we looked at as far as the sample goes. We would send them some pre-course examinations that we don't really use as a program anymore, the syllabus with reading assignments and those kinds of things, expecting that they would work through that information before they would arrive. Oftentimes what we discovered is that people would not engage with that material. We have since used leverage our learning management system for some online modular coursework. We have actually identified, largely anecdotally, some areas where students are not probably as prepared as we would like them to be, given the rapid pace and nature of this particular course that we deliver, in the areas of things like ECG interpretation proficiency, even just talking about lead 2 interpretation, but then also taking it to the level of STEMI identification with 12 leads. Believe it or not, nursing practice does not do a lot with medication calculations the way that a paramedic does, because they are so driven by infusion pumps and other kinds of things where they're plugging numbers into things, that actually having to do manual calculations was also identified as something that there's not a lot of proficiency in. So as we started to identify some of those things, we actually have formalized independent educational modules that they do before they actually even arrive here. Those start about 2 months before the participants arrive in Omaha on campus to then actually engage in the course. And so that there is pre-course work that is done by them to make sure that they do have some entry-level types of competency solidified before they're walking in the door. From that perspective, as you might imagine, they're here for 2 solid weeks, basically Monday through Friday in class, 8 hours a day. We front load very early on the advanced airway types of procedures and components, because that is a shortcoming oftentimes for this audience as well. Nurses from a critical care background work a lot with medications. They work a lot with starting IVs and fluids and a lot of those types of concepts, but advanced airway types of things, and especially some of the alternative airway devices that have made their way now into EMS, those are things that they're not as proficient with. And so that type of content is front-loaded for them. And most of the mornings as you go across that 2-week time span is largely lecture, interactive discussions, cases, a traditional EMS classroom kind of environment where we're largely focused on theory. For this particular audience, it usually boils down to reframing content or information that they already know. We're just trying to make sure that we put, taking care of a woman in labor that's delivering a baby, a nurse's experience might be what happens in a hospital labor and delivery unit, not what's necessarily happening in the back of an ambulance or the floor of somebody's bedroom. So it's a lot about context and putting them in that type of environment, which is essentially important for this audience. The other thing that then happens most afternoons during that 2-week time span, they are in the simulation lab and they are working with mannequins and each other in very small groups of 2 or 3 students to 1 instructor, again, partly because of the limited time frame that we have them here. The other thing, other component that then starts is a field experience type of observational participation with field internship. The students are actually assigned evenings almost the entire time that they're here, as well as on the weekends between the 2 weeks, to actually do capstone internship kinds of team lead roles, where we assign them with a paramedic preceptor that then supervises them. These participants are living EMS education roughly 16 hours a day, almost the entire time that they're here. They do not complete all their capstone team leads during the course here. They actually will either remain with us after the 2-week didactic content concludes. In some cases, if we are able to place agreements and get permission from other states and have a medical director to meet COA EMSP accreditation requirements, we are able to potentially place them closer to home with a local EMS agency there as well. At the end of this, they do take a final capstone written examination, as you had mentioned, and it's in one of our tables that was one of the outcomes that we wanted to look at. Interestingly enough, we give this group the exact same 180 question final comprehensive examination that we give our traditional students that will be with us for our traditional program that's spread out well over a year. It's also interesting, although it wasn't reported in the research because we didn't dive deep enough into that, the scores, if you extrapolate them and look at the highs and the lows and the means, they are almost a mirror image of what we see from that examination with our traditional paramedic students as well. They also do a psychomotor examination that mirrors the current National Registry examination from a psychomotor perspective, with integrated out-of-hospital scenario and some of those things. I would say since this spans 10 years, there were people that would have done the psychomotor examination as it existed before the integrated out-of-hospital scenario was part of that. But that is in essence the program for them and what they experience when they're here.
So a couple questions about the program, and we're getting a few questions in, and I'm going to hold off on a couple of them for just a minute. You said you talk about your initial course and then the challenge course or program. You're saying that the outcomes mirror one another, or the testing process mirrors one another?
I would say both as it pertains to the comprehensive final examination process that we have. We see some of the same pain points as it pertains to content between both groups.
That's interesting. And then do you ever worry that your challenge course students are getting a better designed program with lower student to instructor ratios and more immersive kind of experiences, or how do you make sure that you rectify that? Are they getting equivalent numbers of exposures and instructor contact and physician contact and that kind of thing?
I think so. I think that they're similar. I think the difference is that we're trying to accomplish a lot with a smaller number of people. That's why we limit the size of these classes to no more than 10. But we have less time with them. So while they're in smaller groups, we have the other students for a longer period of time. So I think that the interaction and touch points probably end up being on par with each other.
Okay. So this is the outcome table that you mentioned, that table 2. Can you describe to us then what your, basically when you saw the results, were you surprised at anything? Was this anything that anything jumped out at you as a researcher, or was this pretty much, well, people who have, smart people do well, that kind of thing? Was that sort of your conclusion? And any of you can field that one.
Sure, I'll chime in. So from my perspective, so this is Ash. So my perspective, I think I was not horribly surprised by this. I think it's more than just to kind of leverage some of the concepts you were just putting out there about smart people do well. I think motivated people do really well, right? And so you have individuals who have self-selected, number one, to do external work before even going to a program, applying for that type of program, then going to a comprehensive program for a 2-week period, and then taking a test on top of that. These are people who are driven. And I think all of us in all our teaching experience throughout our careers have noticed this consistent theme, is that if people are strong people who are very motivated and have a true dedication, and going back to a little bit of what Bill was saying about many of them being altruistic, really seeing an inner drive to be successful for others, you're going to see great results like this. Now, I also think that another piece of this that I want to bring up is the fact that this is not in small part also to the hard work is done at Creighton. So I think one of the other reasons that we brought up the whole question of looking at the challenge issue, that when me, Mike, and Bill were really talking about this, is the concept of a consistent type challenge program or something of that nature is a bit of a black box, and it's hard to know what that individual's, number one, going to look like, which Bill has described really well. The second, how they're going to do, which is table 2. But this is not true across the nation. So we know there's 31 programs out there, or 31% of the programs have that, but we don't know what they look like. And so this is really the first attempt to really look at this piece, and it's exciting to see that they are this productive. But again, that's in the framework of what they set up at Creighton.
Okay, I want to bring in a couple of questions here, or comments. So first, Jimmy Eubanks came in earlier. He's from Gaston Community College. Thanks for sending in your comments, Jimmy. He's talking about working with flight teams and ground critical care transport component. And one thing he noticed is that the RNs who maybe the state or the company mandates them to get their paramedic license, they don't really want to be a paramedic or work in the capacity of a paramedic for whatever reason. And this is an observation that he's made. And then, pre-hospital experience, whether or not they're going to actually work as a paramedic. That was one of the questions I had in my little margin notes, scribbles here on the article. Is it would be interesting to follow these completers and find out, do they actually work in the capacity of pre-hospital care or as a paramedic? So that's just a question. And is there any plans to actually do a longitudinal follow-up on your graduates?
So this is Bill. I kind of want to talk to that a little bit. Anecdotally, I also have received that feedback from colleagues in the profession. I think it's important to remember that I don't think that's just necessarily isolated to this particular group. As an educator, we have students in paramedic programs that are using that to get on the fire department, and that's their path there. They don't necessarily want to do EMS. And when you do these programs and you get to know these people, you follow them. And, we've all made friends on Facebook and those sorts of things. There are graduates who, one in mind, she's on Nashville Fire, and she's a very proud paramedic on Nashville Fire. We did have students that come through this program because they do want to get into a community role, and, they see some of the benefits to being on a civil service operation as opposed to working in a private hospital or in healthcare at this time. So I think that yes, there are probably people that have gone through this program that didn't necessarily want to be a paramedic, but I don't think that that's isolated to only this group. I think that we see that pretty consistently across the profession and students. And I would say that there are certainly graduates of this program that are very proudly serving communities as paramedics that also function as nurses.
Another question from Robert Stossel is, does Creighton have a reciprocal paramedic to nursing? I know this question came up before we ever even, put this out there, before we even started the podcast, but do you have a paramedic to nurse bridge at Creighton?
So I'll go ahead and take that. This is Mike. There is not a specific program to bridge from paramedic to nurse through the EMS program. We have a College of Nursing here, and that would fall to them in their particular purview. What I will say is that our College of Nursing here does actually have a program that somebody could apply for if you meet the requirements, which would be the prerequisite coursework that anybody that is seeking a Bachelor of Science degree at the university, if you have taken courses like chemistry and human growth and development and psychology, anatomy and physiology and those kinds of things, they will recognize that. And there is actually a program, it's called an accelerated BSN program. You can actually complete that program in 1 year if you have a bachelor's degree. So there is a reciprocal process that does exist here, and I'm sure that there are those types of processes that exist elsewhere. It's not specifically something that we do through EMS, through the EMS education program. We kind of have our own lane that we stay in. One other thing, if I may add, is that it's important to keep in mind that there is a difference between, and speaking to this as a registered nurse as well, there is a difference in educational approaches and philosophy between EMS and nursing programs. Registered nurses are going through an educational endeavor that is teaching them to be a nurse generalist, to take care of patients in a multitude of environments. It could be a private clinic, a dialysis unit, to critical care, operating rooms, all different kinds of environments. And a paramedic has got a much more focused, I think, educational experience that is really focusing in on emergency medicine, critical care kinds of things. And so I do think that we need to recognize that there is somewhat of a difference. I think that with the implementation of community paramedic programs and some of those kinds of things, that difference will continue to narrow as far as what's going on. And then one final comment to add here with what Bill said in the question about, do these graduates actually work then in EMS? I would also want to mention here that oftentimes we see graduates that are using the paramedic education program to go on to other kinds of things, med school, physician's assistants programs, those kinds of things. But we also are seeing more and more frequently paramedics that are being recruited by hospital environments to bring their skills and their knowledge to work as part of highly sophisticated team-based models to actually deliver care in a variety of settings. One might think that that's limited just to the emergency department. We have a children's hospital in our community. A couple of years ago, they started hiring paramedics, preferably with a degree, to actually work side-by-side nurses in a team-based model in their critical care unit with the sickest of the sickest kids. And that program has been functioning at a very high level and doing great work. So I think the future of what we're doing here from an education perspective in EMS more broadly, kind of getting off topic of this particular research, that I do think is a project that we need to explore, is where are traditional paramedic students ending up. More and more we see them not choosing to be in the back of an ambulance and function clinically in other areas.
I don't think it's actually off topic. I think that you're expanding on something that, because at first read, I think a lot of paramedics who came up, like, many of us traditional, through the EMT program and then into paramedic, see this and say, okay, what are the implications for community paramedicine? Is this, a grab at the community paramedicine, by nurses? Is this, it's automatically sort of this immediate visceral defensive approach, and you have to kind of put your amygdala away for a second and say, okay, let's think about this. And I think you hit on so many points there, Mike. One is, and Michael Presta actually asked about what about the associate degree in nursing, that we're answering to the bachelor's program. But in California, I know in our area, in the Bay Area, we have a number of things that are cropping up now, just gradually, and one of those in the associate degree in nursing programs are multiple criteria. And in those multiple criteria, meaning for entry, so, some of them were so impacted they were using lottery systems, which are terrible. Just throw a bunch of names and you start drawing them out. Anybody who met the prerequisites of the science prerequisites and whatever, they could just be drawn out of a hat. Now with multiple criteria, we have people with the appropriate clinical experience, and in there is paramedic. You're actually gaining a number of points, and so now I'm noticing from our program, from the community college paramedic program, a number of our graduates being accepted into not just associate degree nursing programs, but that's definitely one of the paths, but also into the accelerated BSN programs and in the master's entry paramedic or nurse practitioner programs or nursing programs. So we're seeing it at all levels. The other thing I think you absolutely hit on, and I know this is a point that is close to your heart, is interprofessional education and interprofessional education and collaborative practice. So maybe this is something that lends it to interprofessional education. We have Kim McKenna. I don't know if Kim is unmuted. Are we unmuting Kim here, or should we just pass on her question?
Well, Megan, can you hear me?
Yes.
Excellent. Well, thank you, first of all, for all the authors and a wonderful research piece. This is Dave Page, and we're at a workshop for educators here who are all tuned in, listening, and had a quick question while Kim gets unmuted or through, and that is, how many hours exactly of clinicals versus, so hospital clinicals versus field, do these nurses actually perform?
So there is no requirement from a clinical perspective because they have really done that work. When you think about the clinical experiences that we have paramedic students complete, with these people having completed a nursing education program and then clinically actively working for a minimum of 2 years in a critical care environment, that's not something that we as a program have felt that they needed to repeat or go do. As far as the field goes, we put them, it's not hours based, number one, it's competency based. So we're looking at them to attain, the number we give them is 50 successful team leads. We subscribe to the definition of what a typical team lead is that you would see. I think on the form that's been going around for a number of years, I think started in California, that's been part of the NAEMSE educator textbook, is largely that evaluation form. So that is what they have to accomplish, and it's really looking at those demonstrated competencies to lead a call, do the assessment, obtain the history, physical examination, and put forth a treatment plan that would be EMS specific and appropriate in the out-of-hospital environment.
Well, so that sounds great, and for the audience, Mike is a great friend, so I appreciate the answer. We're the educators here are grappling with some of the questions, and it's wonderful to hear you kind of articulate that. So you really kind of eliminate anyone who's just a new grad from a nursing school. It's really only people who have critical care experience in 2 years of it. Did you verify that?
Yes, that's exactly right. Dave, they have to have that 2 years of requisite bedside experience. We're even looking for that to be full-time experience, not somebody who is working one shift a week. It also has to be contemporary experience as far as, we even look at, somebody who presents themselves maybe having worked in an ER for 2 years, 25 years ago, that is not necessarily the candidate that we're selecting for participation, and actually regularly decline people who apply. And even more than that, get tons of inquiries about this particular program of people who want to come do it that just don't meet our requirements. New grad nurses that want to get into critical care environments that we say, you know what, go get some experience for a couple of years and then come back and see us. That isn't the only metric, but that is one of the metrics that we look at as a minimum.
And I noticed that you listed the number of people who you admitted. How many do you reject for those that you admit?
The researcher in me tells me that I should have that answer, but the reality is I don't know.
No worries, no worries. And then a follow up on you're putting these folks that are from out of state on Nebraska ambulances. I'm assuming the state of Nebraska EMS office wants your paramedic students to be EMTs before they actually care for patients. They can cross the state line as a nurse and perform complicated invasive procedures, and we're okay with liability. Do they get special liability coverage? Do you do anything special around that?
So all of our students through the university, as a very, very strong health sciences offering university, we have comprehensive insurance on every student, no matter what their status or capacity is. As far as the EMT point, which is covered and addressed in the article, they are also required to be EMTs to qualify for this particular advanced placement course. Now, it's not necessarily based on them working or having experience, but they have to be a card-carrying emergency medical technician and have to have gone through a course that makes them eligible to take the National Registry examination or a state credentialed examination in order to participate in this course as well.
Great, thanks, Dave, and the workshop participants there. Kim McKenna wanted to know about the overall pass rates on the psychomotor exam, and on page 47, you talk about the overall pass rate after 3 attempts was greater than 99%, but of these individuals, 175 passed the paramedic psychomotor exam, indicating entry-level competency, 88%. She wanted to know about what you did for the remediation process. So if they failed a station, how were you able to achieve remediation?
I'll address this. This is Ash. So one of the things, and great question, Kim, because I think that's a big piece is whether or not they are truly satisfying that entry-level competency, and the psychomotor piece really helps you kind of delineate that out. So one of the challenges that we had in this study, and I think that a lot of people are going to see across the whole concept of the advanced places or the challenge, is that there's a difference between what we a lot of times want an entry-level competent EMS provider to do, meaning doing the cognitive exam and the psychomotor exam to go to the point of then asking for licensure, and what is exactly required for licensure for people who are advanced placement physicians. So many times, even just the cognitive itself can be for licensure sufficient, and that totally depends on the state, and that study has not been done to define exactly what each state would like to have for licensure of advanced placement individuals. So we don't know the full answer to that question. So what we had in our study is of the individuals who actually sat for the cognitive, 175 actually took the psychomotor exam. So what we don't have is the other group of individuals who did not take the psychomotor exam. So that percentage is directed at the individuals who actually sat for the psychomotor. Of everyone who sat for the psychomotor, they passed, and they actually went through the same type of remediation process that anyone else who would have to go through, who failed, would have to go through for remediation. So really, no difference in if they're going to challenge the test, they're going to satisfy the same kind of criteria that you have to do.
Bill Toon is online too. Bill, you got some input here? Is Bill Toon on with us?
Megan, this is Mike. One other thing that I might be reading into Kim's question a little bit further here. beyond what Ash was able to address. As far as remediation goes, we do not abandon these students after they leave here after a couple of weeks. We know that they're oftentimes going all over the country afterwards. If you look at the figure 2 in the paper, we make ourselves available to them for remediation. So sometimes there are things that we can talk through using technology. There are other types of things perhaps that are hands-on that we may actually have to have them come back to campus. We have had people who have done that have potentially needed remediation for whatever skill that they needed from a psychomotor perspective, and they will make their way back to us. We have also reached out on rare instance, but this did happen one time with Kim, actually, and we very much appreciate that opportunity to work with her as a colleague, where somebody was in her area and we were able to get that person connected with her. So we do try to make sure that we have resources available and the ability to handle some of those logistics that oftentimes might be forgotten for somebody in this type of environment.
Thanks, Mike. Bill, are you unmuted now?
Well, Bill figures out his microphone. I guess I had a question about cost for this, Mike, and just the feasibility, the scalability of this. It definitely sounds like it's a very catered, very, very precise program that's hard to duplicate very easily, especially at 10 students at a time. But how do you feel about cost? Is it, and are there areas, whether with Logit scores or scores from exams, where you're seeing particular gaps that you think are part of what makes a difference between the candidate that took an NCLEX versus a registry exam, or the candidate that has critical care experience in the hospital versus the field? Do you see those differences, and what's the cost?
So the cost for the course is probably the cheapest component. Don't quote me on this, but I want to say that the cost for the course is right around $3,000 that we charge. There are, however, a lot of expenses that are not captured in that. We all know probably what it's like to go to a conference and those kinds of things. If these people are traveling and not local, and we do have people that are, of course, local that participate in these courses as well, but there are, hotel expenses, traveling expenses, time off of work in order to be able to come do this unless their employer happens to be sponsoring them. There are a lot of things that have to be factored in for that. And I can't tell you exactly what the cost is for all of these people as it pertains to this. I don't know if Ash has any information about Logit scores for this particular type of audience, for example, on the National Registry examination, that he could potentially speak to, as opposed to people that wouldn't be from an advanced placement perspective.
That's a great question, and it's not something that we've delved into. Again, I think it comes back to the fact that these are very high-performing students in the first place, because then you would almost have to think in terms of the comparative group. The comparative group should be high-performing individuals who have experience, right? So it's kind of an unfair comparison to look at a Logit or just where they would fall for specific. And of course, the National Registry exam is very much designed at entry-level competency. So you're looking at where you fall, where's that cut point, rather than how high you really got. So I don't really have great data on that concept, but I think one of the big things that we have to keep in mind is we're definitely looking at a different population than what our true entry-level paramedic would be.
Hi, Bill Toon trying. Hello.
Welcome,
Hi,
Bill.
Hi.
Oh, no, Bill's unmuted. Watch out.
So, first of all of the students with Dave Page right now, my great apologies for your experience that you're having right now. And if you had wanted a real educator, you should have contacted me, but that's okay. Hi, Dave. So get down to the point here now that I've picked on you. So a couple of things here. So and correct me, all these students that go through this advanced placement are eligible to sit for the National Registry exam because you're an accredited program, correct?
That's correct.
Okay, so the second piece of it, and I'm going to go back in ancient history. Back when I ran a paramedic education program in New York State, we had an advanced placement policy in place by the state health department, and we used to take nurses, and as long as they had an EMT, and we would evaluate them on an individual basis and put them through our paramedic program. And some needed many more hours than others. Some that didn't have critical care had to do critical care, but it varied greatly by the individual. And then also where I worked in New Jersey, we had mobile intensive care nurses who did not have to be paramedics, but they had the certification as a mobile intensive care nurse, and they were my equivalent. And I worked with many of my partners when I worked in New Jersey were mobile intensive care nurses, and were excellent. Actually, I liked the balance of the nurse paramedic combination that we had there.
Yeah, Bill, you raise a really good point in that there are many states actually across the country that will actually, in Nebraska, interestingly enough, is one of them, there is no restriction on nursing practice as far as their scope goes in Nebraska. If a registered nurse wants to affiliate with an ambulance service in Nebraska, she or he can do that with the medical director and the agency and actually function in that ambulance as a part of that crew. So in many cases, I spent some time in my career in Illinois, and in Illinois they have a pre-hospital RN as well, a PHRN, which sounds similar to what you had, I think you said, in New Jersey, where basically with the blessing of the medical director who signs off on that person, they don't really have to have any education. Mostly what they address from my experiences in Illinois is, can you intubate a patient, is basically what it boils down to. And they will usually do that in a very short in-service, oftentimes with the medical director or one of their designees. So it's not unusual for those types of instances and those types of things to occur. Statutorily, Nebraska in the past has formally codified that these, both at an EMT level and paramedic level, that these types of advanced placement courses can take place and exist.
Hey, we're at the...
Oh, I'm sorry. I'm just going to say in ending, I think there's a lot of stuff going on nationwide that we don't know regarding to different practitioners practicing in the field as pre-hospital providers, and then pre-hospital providers practicing back the other way. I think it's a big unknown.
Yeah. Any final comments from others? And actually, I think Dr. Patchell, you wanted to make a comment about the workforce and community paramedic concerns.
Yeah, you surprised me a little bit about the concept of us thinking that this would be kind of a bit of a land grab towards community paramedicine and things like that. And I think one of the things that we have to keep in mind is the larger framework of our workforce and the dynamics we have right now. And I think going back to what Bill just suggested is that there is a lot of unknowns out there. But what we do know about our workforce, especially when we think about small regional or local areas, is that there are areas that we have shortages of workforce, individuals to fill in spots. The other piece we have to think about is that we are also losing a lot of our workforce of great paramedics who are very skilled to other occupations due to pay and to those different things. And so the last piece is when we do have people entering our workforce, like these nurses or respiratory therapists or whoever they may be, it is good to see that some of them are getting trained to the point that they are going to be actually functional individuals, such that if something happens on the side of the road, that they could actually serve as an EMT or a paramedic in that space. So there's a lot of challenges and a lot of dynamics here. And I think the more we look at it, the more questions we ask about it, then we'll finally start nailing this down. So I loved your comment about, suppress the amygdala and look at this as the bigger picture, because long term, it's going to be a lot of us holding hands and working together to try to find the best solutions for our communities.
Thank you for that, and I'm glad you brought up the workforce. The other thing I think is great is at least Mike, Dave, and I know are site visitors. I don't know if anybody else on here is for the COA EMSP, and the advantage to that is you have not only do you get to go see other programs, you get to sort of see other systems. And one of the things about accreditation is, yes, we follow standards of accreditation, so it is to some degree standardized and maybe uniform in one sense, but it also recognizes that you need to look inside your own industry advisors and your own community, and what needs you fill in your own community. And in that regard, what resources you have to do something like this versus something else. And one of the other things is I'm from a community college with an equity agenda, and it's clear and crystal clear in our mission what we do. So something like this may not be, when you say only 18% use their challenge process, that doesn't surprise me at all where I am. We just could not possibly commit resources to something like this and ignore what our primary mission is at the community college that I'm at, which is to provide upward mobility for first generation college students, unrepresented students, single parents, that kind of thing. So we're thinking from a different lens. So it really depends upon your community needs as well. Any other thoughts here to close out this discussion?
Thank you.
I just want to say thank you again, and I hope that this paper is motivating to other programs to kind of, how do you kind of approach a descriptive or feasibility study for some things that maybe you're doing that's innovative and potentially beneficial for our profession or community. And again, I just want to say thank you. And I want to acknowledge the support that the Journal of Emergency Nursing gave in publishing this.
Yes.
They worked with us they were very excited to have this article, and they worked with us to get it fast-tracked and distributed on our timeline. So if you're looking for a great journal to work with out there, JEN is recommended by at least this researcher.
Great, thank you all, and thanks to the authors for joining us, Dr. Mike Miller, Dr. William Leggio, and Dr. Ash Panchal. It's always great to have the authors so we can ask those questions and get it straight from you rather than trying to interpret ourselves. So thanks everyone for joining us. The PCRF Education Research Podcast will be back again on Friday, March 27th, 2020 at 10 a.m. Pacific, noon Central. But remember, the next PCRF Clinical Podcast will be Monday, March 9th. If you do want to present an upcoming article or you have ideas, send an email to David Page at dpage@emsed.net. Thank you all. See you next time.